Hello everybody, I am Dr. Gabriel Pardo. I am the director of the Oklahoma Medical Research Foundation Multiple Sclerosis Center of Excellence. I am very pleased to be here with you today doing what is the first of a series of presentations that the National Multiple Sclerosis Society has put together for all of you to increase your knowledge and understanding of this very specific and complex disease, multiple sclerosis. And I am very pleased that you're here today. I am going to do the presentation, and we will have time towards the end of it for questions and answers. You are welcome to type into your computer your questions. Those will be forwarded to me and we can address them at the end. So at any point in time, please feel free to ask the questions and we will get to them towards the end. Before we talk about multiple sclerosis itself, I want to discuss why is it that it is important to talk about multiple sclerosis. What is the dimension of the problem in multiple sclerosis? I am sure that every single healthcare professional is going to be dealing with a multiple sclerosis patient in their lifetime, and many of you are going to be dealing with a lot of multiple sclerosis patients. And that is because multiple sclerosis, even though it is a not very common disease, certainly it is not something that is not seen on a regular practice. Approximately 2.1 million individuals worldwide have multiple sclerosis. We believe that there is approximately 200 new cases of multiple sclerosis diagnosed every week worldwide. And that, of course, gives us a significant population of individuals out there that are affected by multiple sclerosis, for whom we need to be prepared to take proper care and action. There are some specific characteristics of multiple sclerosis that makes it interesting as it pertains to the epidemiology of the disease itself. One of them is that, like other autoimmune diseases, the case in multiple sclerosis is that there is a significant predominance of females over males at a ratio that is estimated nowadays to be approximately 3:1. The average age of diagnosis of multiple sclerosis is 30 years old, but MS can be diagnosed at any age. It affects every age. We have pediatric cases of multiple sclerosis, and we certainly have cases of patients that are diagnosed with MS for the first time in their 60s, sometimes even in their 70s. The clinical manifestations and the disease course of multiple sclerosis is extremely variable, and that of course makes it necessary for us to be even more engaged in knowing more about multiple sclerosis, to be able to recognize not only the different types of manifestations and presentations of the disease, but also how to best target them. And that again is the purpose of this series of presentations: give you more exposure to multiple sclerosis, the characteristics of the disease, and then of course how to approach them. What we're going to do today is talk about some of the basic information of multiple sclerosis, and hopefully this will set the groundwork for future presentations. So that being said, let's move on to discussing what is multiple sclerosis. And MS is primarily an inflammatory disease that affects the central nervous system. And this is a very important concept because MS will not affect peripheral nerves. Only the optic nerves, the brain, and the spinal cord are affected by the inflammatory process that is characteristic of MS. It is a chronic disease. MS will never go away. Again, the manifestations are going to be extremely variable. Some patients will have periods of quiescence when they do not have any specific symptoms or manifestations. That does not mean that the disease has gone away. Once you are diagnosed with MS, you have MS for a lifetime. We're going to discuss the pathophysiology later on, but we know that MS is an immune-mediated disease, and it forms part of a large group of diseases considered to be autoimmune in nature. And again, we'll review those characteristics in a second. The clinical course is extremely variable, not to speak even of the different types of multiple sclerosis, but within each type of MS, patients might have very mild manifestations or can have significant disability secondary to multiple sclerosis. And there are few clues that we can have early in the disease process that will give us some information as of how that patient might fare down the road regarding the course of their disease. There are different clinical types of MS that we'll review in a second, as well as different described pathological processes. When brains of patients with multiple sclerosis have been analyzed histologically, then different types of abnormalities have been identified. Unfortunately, there is no specific correlation between the pathophysiology of MS, the histologic types of MS, and the clinical manifestations of MS. So even though these are great advancements that are going to allow us to learn more about multiple sclerosis, those correlations cannot be, at least with our current understanding of the characteristics of each one of them. The impact on patients is quite significant, and it comes in many different ways. We're going to review how the most common type of multiple sclerosis, relapsing remitting MS, presents with episodes of acute neurological dysfunction. When a patient has an episode of acute neurological dysfunction, of course, for the most of them, there's going to be a functional impact that is going to impair the ability of the patient to perform different types of functions. As a consequence of that, quite commonly, a patient will have a sustained physical disability. That is the residual effect of that process of inflammation and demyelination, and in many cases destruction of the nerve cells, that will impair the function of that specific area of the CNS with its clinical manifestation. But beyond that, in addition to the deficits that are accumulated from specific relapses, the patients can also experience progression of deficits, even in absence of relapses. And those characteristics will define the different types of multiple sclerosis that we're going to talk further on. But we also have to be cognizant of the fact that in addition to all of these physical manifestations that we're talking about, there are other aspects that are also affected by multiple sclerosis that also require our attention. And one important one that has been the focus of a lot of research recently is cognitive dysfunction. And again, we'll get a chance to talk about that during this presentation. So these are the types of multiple sclerosis. 4 clinical types of MS have been defined, and you see them right here on your slide. The most common one that affects approximately 85% of patients at the time of diagnosis is relapsing remitting MS. What are the characteristics of relapsing remitting MS? As we have mentioned earlier, patients are at their baseline, usually with no neurological deficits, and then usually in a subacute fashion, and by that I mean in a matter of hours or days, there is a specific deficit that appears and worsens, and it reaches a plateau, a maximum deficit. That deficit, whatever it might be, and we're going to review those later on as well, will stay with the patient for usually days to weeks, sometimes even months, after which the patient will experience either partial or complete recovery. So this is one of the ways in which a patient can start having some specific functional deficits due to the relapses that are causing these problems. The activity in between episodes is going to be very minimal. A patient is left with a deficit or no deficits and will go through a period of time where they have no new neurological deficits until they have another manifestation. And usually that next deficit is of a different kind, not the same one that they presented with the first time. That course again characterizes what's called relapsing remitting MS. Most patients, if left untreated after 10 to 12 years of having this type of multiple sclerosis, will evolve into a different type called secondary progressive MS. In secondary progressive MS, what we see is that there is a slow worsening of the baseline deficit over time, whatever that deficit might be. And the frequency of relapses is very, very low, or they are not present at all. We believe that this is present because there is a shift in the pathophysiology of what is happening in the central nervous system regarding MS, and again we'll review that later on. Another type of multiple sclerosis that affects approximately 10 to 15% of patients at the time of diagnosis is primary progressive MS. And primary progressive MS is characterized by the presence of a mild neurological deficit that slowly worsens over time, and the patient never has an acute or subacute deficit. So all they witness is a slow progression of a specific deficit. An even less common type of multiple sclerosis is progressive relapsing MS. Basically, it starts as primary progressive, a mild deficit that worsens, but at some point in time in the course of the disease, they have a superimposed deficit. They actually experience a relapse. Again, that is less common. Something that I really want to highlight, because it's a common misconception, is that the type of MS does not imply severity. People that are diagnosed with primary progressive MS tend to believe that they have a worse type of MS, that they're going to course more rapidly or they're going to accumulate more deficits. And even though that might be the case, it is important to recognize that many patients with primary progressive MS will have minimal deficits that will not have a significant functional impact, while there are patients with relapsing remitting MS that even in very early stages of the disease will have significant deficits that will render them unable to perform specific functions. So let's move on to the pathophysiology of multiple sclerosis. I mentioned earlier how we know that this is an immune-mediated disease. It is considered to be, again, an autoimmune disease, and by that we mean that it is your own defense mechanisms, the ones that are responsible for attacking parts of your own body. Different autoimmune diseases have a different target. In the case of multiple sclerosis, the target of that attack of your own immune system is myelin, the insulation around the nerve cells in the central nervous system. So as a consequence of that inflammatory process, we're going to see two specific consequences. One is demyelination, or loss of myelin, and the myelin is there and has a specific purpose, which is to enhance the action potential, the speed at which electrical impulses are conducted through nerve cells. But also, as a consequence of the inflammation, many patients experience axonal damage. The actual nerve cell is attacked either directly through inflammation or die due to the lack of trophic support from the myelin, and then you have axonal loss. Myelin can be regenerated. So if the attack is limited or is predominantly affecting myelin, then the cells that are responsible for laying myelin layers around the nerve cells, called the oligodendrocytes, are able to regenerate that myelin. And that is what, for the most part, is responsible for the recovery after an acute relapse. But, as you all know, we do not have the ability to regenerate nerve cells. So once a nerve cell is dead, there is no way to bring it back. And that might be responsible in many patients for fixed deficits. Now, we know that some patients, due to neuronal plasticity, can also recover from deficits even if there is axonal damage, but the odds are certainly lesser. There is a second component in addition to the inflammation that causes demyelination and axonal damage, and that is a process of neurodegeneration. And that has been has been characterized in a lesser way compared to the inflammatory component of multiple sclerosis. We believe that this process of neurodegeneration is the one that is responsible for the progressive stages of multiple sclerosis, particularly secondary progressive MS. Remember that we discussed that from a clinical point of view, patients shift from having acute relapses to having a slow worsening of deficits. And we believe that that is a shift, again, in the pathophysiology of that process. This slide illustrates in a very basic manner the immune system activity in multiple sclerosis, and I'm going to walk you through it. It's very simple, but I do want for you to understand what we believe happens. And again, this is a very simplified model of it. In the bloodstream, we have cells that belong to the immune system. And one of their functions, a very important one, is to fend us from infections, either viruses or bacteria. So we have cells that are monitoring our body for that purpose. And once they have identified one of those foes, virus or bacteria, they're able to attack, destroy them. But then they're going to generate something that's very important, and that is immune memory. And immune memory is what is going to allow us to defend ourselves against this same virus or bacteria if we're presented with them again. So these cells called macrophages have done that function of degrading or attacking the bacteria or viruses, and then they present chemical characteristics of that specific pathogen to the immune system, and those are the T cells. And these T cells again are going to create the immune memory to recognize that later on. These T cells are circulating in the bloodstream, and eventually they gain access into the central nervous system, as you see here. Once they're inside the CNS, and this is the brain compartment now, those T cells are presented by the equivalent cells in the central nervous system of the macrophages that are going to tell the T cells where it's around. And they are presented with components of myelin, and this is where the case of mistaking identity takes place. The T cell misrecognizes then this component that is actually part of your own body as something foreign that needs to be attacked, and then it creates this inflammatory response that through different mechanisms that include cells and antibodies and chemicals like cytokines and chemokines, the attack that, as you see here, is going to be targeting both the myelin but also causing damage to the nerve cells. So this is the pathophysiology of the inflammatory component of multiple sclerosis. And we are able to see that the consequence of that inflammation and damage, not only clinically, when we examine a patient and we see the deficit as a consequence of that, but also, and to a greater extent, I will argue, in MRIs. And the MRI has really revolutionized our approach of multiple sclerosis because it is allowing us to do many different things, one of which is to enhance our ability to diagnose multiple sclerosis early, but also to monitor how well we're doing regarding treating multiple sclerosis patients. And this is what an MRI will look like in a typical multiple sclerosis patient. This is a sagittal view, a side view of a patient with MS, and what you see as depicted in white are areas that have been damaged by multiple sclerosis, all these areas here. This is a typical distribution of lesions in multiple sclerosis right around the lateral ventricles, and usually with a perpendicular distribution, meaning that they're at a 90-degree angle of the ventricle like you see right here. In addition to periventricular lesions like this, in multiple sclerosis we also see juxtacortical lesions, lesions right next to the gray matter, like this one right here. On an axial view, so seen from below, again we see lesions that are right next to the ventricles like these ones, and we see lesions that are right next to the cortex. We have learned recently that the lesions in multiple sclerosis do not only affect the white matter, but that they also affect the gray matter. And one could argue that in this MRI, even though it's not specifically done for this purpose, the type of MRI is not very specific, one could argue that in this lesion we can even see involvement of the cortex of the gray matter, as well as one could argue the same thing right here. So we see involvement of the brain, but we also see involvement of the brain stem, and this is an example of that, a lesion in the medulla, and also of the spinal cord. Cervical, thoracic cord can be involved, cervical cord more commonly in a clinical basis, and you see a lesion right here at the level of C2. And of course, according to the area of the brain or spinal cord that is being affected, a specific function is going to be lost. These images that I just showed you in the previous slide are, and I'm going to show them just one more time, are done with a specific type of sequence in the MRI that really highlights the lesions, and this is what is called a T2 flare image. It really allows us to see all of those areas quite well. For infratentorial lesions below the tentorium, brainstem, cerebellum, then fully T2 weighted images are more appropriate for us to identify those lesions. Now, there has been a lot of development in different modalities of MRI. We will not go into that are allowing us to look at all of these aspects in more detail and shedding light into a lot of different processes in MS. A consequence of these processes of inflammation and a loss of nerve cells, of course, can be not only the accumulation of some of these lesions as we just saw, but also the loss of brain volume. So brain atrophy can happen in multiple sclerosis. And this is an example of that. This is the image of a single patient, MRIs that are done over a 7-year period. This is at the same level of the brain, and you see how at baseline we have a brain that looks fairly normal. The ventricle size is what one will call average, and the depth of the sulci is normal. And you see how over 7 years we have significant development of atrophy, which you can judge by the increased size of the ventricles. The hole is larger. That's when you're digging a hole, the more dirt you take away, the bigger the hole. That's what has happened here, as well as the depth of the sulci appears to be increased. Again, demonstrating the fact that brain atrophy happens in multiple sclerosis as well. Brain atrophy has been associated with multiple different deficits. Specifically, it is associated with greater disability and cognitive dysfunction. So this is also an important aspect to monitor over time, even though in clinical practice this is not easily done. So let's move on now to the actual clinical manifestations of multiple sclerosis. I'm just going to mention them now because once we're talking about them later on regarding what to do about them, we'll go into more detail about them. But basically, as you can see here, the list is very long, and this is not a comprehensive list, but only the list of the most common clinical manifestations. A very common one, of course, sensory abnormalities, and sensory abnormalities can be either negative sensory abnormalities, by that I mean numbness, absence of sensation, as well as positive ones, and those will be paresthesias, tingling, burning, even pain. We have motor deficits. Those are extremely common in multiple sclerosis, and you have different degrees of weakness that can be seen in MS depending on the area that is being affected. We have optic neuritis, perhaps one of the most classic symptoms of multiple sclerosis, and the one that leads to the diagnosis in a significant portion of patients, because in the medical community there is a good sense nowadays that a young person with optic neuritis more likely than not has multiple sclerosis until proven otherwise. So that really takes the patient into the appropriate path of evaluation and diagnosis really fast, and that is the reason for which optic neuritis is one of those symptoms that leads to the diagnosis. Quite typically, a patient with optic neuritis will complain of some blurriness of their vision that can be just in the periphery or the central portion of their visual field, and this blurriness worsens over a matter of hours to days. Some patients have mild dysfunction, some patients have complete loss of vision. Like with any other symptom of MS, the presentation is extremely variable, and then they tend to recover after some weeks. Diplopia or double vision is also another common manifestation of multiple sclerosis due to involvement of the brainstem, where the centers for control of ocular movements reside. The most common type of deficit in this regard is something called internuclear ophthalmoplegia, also known as INO, in which the ability to move your eyes in lateral gaze, either to the right or to the left, depending on the area that's being affected, is compromised, as the eye that is adducting, the one that's coming towards the nose, is unable to do so, either the degree of movement or the speed of movement with respect to the other eye. But also we see other types of manifestations. 6th nerve pulses, 4th nerve pulses can be seen in multiple sclerosis as well. Other symptoms include vertigo, ataxia. Ataxia can be either due to involvement of the cerebellar pathways, or it can also be secondary to sensory abnormalities. You can have a proprioceptive ataxia due to loss of proprioception in the lower extremities. Neurogenic bladder and bowel, for that matter, can also be seen in MS. As we affect the spinal cord, we affect all of these pathways of control of bowel and bladder, and patients can have manifestations that are commonly in the way of frequency and urgency. And two, very briefly, different mechanisms for this can be either a spastic bladder that does not allow you to accumulate enough volume in your bladder before you have the urge to evacuate, as well as the trusor sphincter dysynergia, a process in which the contraction of the bladder muscle is not coordinated with the aperture of the sphincter, and then when the patient attempts to void, they only void small volumes and the bladder fills up very fast after that. So even though the mechanisms are very different of how the symptoms are happening, the manifestations are the same, urgency and frequency. So it depends on either the neurologist or perhaps a urologist to determine which one of the two processes are present, because the treatments certainly will vary depending on which one of those we're dealing with. I mentioned earlier how we are becoming more aware of cognitive deficits and the need to address those, and those certainly can be a manifestation of MS. We have pain, and pain is a very important element to talk about, because we cannot ignore that, and pain can come in many different types in multiple sclerosis, either due to direct involvement of nerve cells that are responsible for sensation, but also through indirect mechanisms, like for example spasticity or alterations of gait that are putting more stress on specific joints, and they're creating musculoskeletal pain that, even though it's musculoskeletal, is secondary to the underlying process of multiple sclerosis. Sexual dysfunction, both in males and females, is also something that we need to address, as it is a very important part of human development, personality, and interactions. Spasticity, a very important aspect for which there are many different methods to approach depending on the severity of the increased muscle tone, and some symptoms that are not very well described or for that matter understood, but that have a dramatic effect on the functionality of our patients, and that is, for example, fatigue. With that long list of symptoms, it obviously becomes very reasonable to have a comprehensive care plan to be able to treat these patients properly. And our goals are going to be very specific. We're going to try to prevent deficits. We need to improve the ones that are already there, and once they are fully established, we need to optimize function with whatever we are left. We need to address both the disease process itself as well as the symptoms. We cannot just say, I'm treating your MS, I am not treating your symptoms, because they're an integral part of the management of multiple sclerosis, hence the need for a comprehensive care plan. And also, in addition to that, dwell into all of the social aspects secondary to these deficits that might ensue for our specific patients, related to work, related to finances, even leisure activities, and family interactions. So what do we do from a medical point of view to treat multiple sclerosis? These are our goals from a medical management perspective. We are able nowadays, with our available treatments, to reduce the risk of these three things. Having new relapses, we want to reduce the frequency at which we see relapses happening in our patients. We also want to reduce the possibility of seeing new lesions or active lesions or enlarging lesions as documented by the MRI. The MRI gives us good insight into what is going on, because many of these lesions that we see in the brain or spinal cord, we are not able to identify clinically, and the patient might have no symptoms from them, but the MRI again gives us a sense for to what degree we are fully controlling the process or not. And we also want to reduce the risk of the patients having progression of their deficits. So those are the three goals that we can truly achieve with our current treatments nowadays, and this is what we're of course trying to do in our patients. Now we of course are faced with other sort of circumstances, like for example when a patient has an acute relapse, and we need to talk about what do we do to intervene in an attempt to limit the damage and hasten the recovery of that process. And then once the deficits are established, how can we optimize the function? So how do we go about doing all of this? By using these types of medications. To reduce the risk of having these problems, we either use immunomodulators for the most part, or less commonly immunosuppressants. These are the different types of immunomodulators that we have available nowadays, and we're going to go through them in very brief detail. The first group, and actually the first medication ever approved for management of multiple sclerosis, is the interferons, and we have two types, interferon beta 1b and interferon beta 1a. There are two brand names for interferon beta 1b, Betacedron and Extavia. For all intents and purposes, they're the exact same medication administered subcutaneously every other day. Interferon beta 1a comes in two forms, Avonex, which is administered intramuscularly once a week, and Reviv, which is subcutaneous 3 times per week. And then we have Glatiramir, known commercially as Copaxone, administered subcutaneously daily. These medications that we have in this slide are considered to be the conventional immunomodulators, the ones that we have been using since the 1990s, for which of course there's a lot of communal experience accumulated on them. We have some newer medications that have come to market in the last 2 years, including the first oral medication for MS, fingolimod, commercially known as Gilenya, taken as a daily capsule. We also have natalizumab, or Tysabri, which is intravenous, and I need to correct myself here, natalizumab has been available for more than 2 years at this point in time. Tysabri is administered intravenously every 4 weeks. And we have a more recent oral medication, teriflunomide or Obagio, also given as a daily pill. There is another one that is impending approval from the FDA, and that is why it has a question mark right there. The expectation is that we will have that medication available in the very near future. It's going to be known commercially as Tecfidera, administered orally. The studies looked at this medication in 2 different doses, twice daily and 3 times daily, and of course how it's going to be approved, it is not yet known. Possibly we'll have both options, but again, this is not known quite yet. All of these medications again are going to allow us to reduce the risk of having new relapses, are going to reduce the number of new or enlarging or active lesions in the MRI, and are also going to variable degrees reduce the risk of having progression of disability. That last component, the effect on progression of disability, is the one that we are less effective in actually modifying, and the one that is the target of more extensive research nowadays. Immunosuppressants can also be used, and they can be used in different settings. One is as an induction therapy, when you have patients in whom you find significant amount or uncontrollable degree of inflammation in the brain. Some physicians might opt to use these immunosuppressive therapies to try and control the inflammation more aggressively from the beginning. They can also be being used as adjuvant agents in addition to an immunomodulator, or also in treatment of progressive stages of the disease, like secondary progressive MS and in some cases primary progressive MS. Now I have to clarify that all of these uses that I'm describing and all of these treatments are being used off-label, except for only one, mitoxantrone, that is indeed approved by the FDA for use in multiple sclerosis. When mitoxantrone is used, it is given intravenously every 3 months. Its use has really declined in recent years as some potential serious complications from the use of this medication have been recognized, to include cardiomyopathy with secondary congestive heart failure, as well as the induction of leukemia. Other medications that are used by the MS community include cyclophosphamide, azathioprine, mycophenolate, and methotrexate. And again, the use of these medications is off-label. How do we manage acute relapses? Well, one thing is that we do not need to treat absolutely every single relapse. The intervention in relapses is geared towards really improving the functional status of the patient, limiting inflammation, and hastening the recovery. So if a patient has a mild relapse, say an optic neuritis that does not have a significant impact on visual function in any way, or a patient has an exclusive sensory relapse also that does not have an impact, then we don't necessarily need to treat the relapse as such. We need to take that relapse into consideration as of how we're managing and properly managing the overall disease, but we do not have to actually intervene for that relapse. But when we decide to do so, say an optic neuritis with significant visual compromise, or a transverse myelitis that's causing paraplegia or paraparesis, then we do want to intervene, and the most common way to do so is by using intravenous steroids in the form of methylprednisolone, usually from 3 to 5 days. If that fails, there are studies that have shown the efficacy of other types of interventions, such as plasma exchange or plasmapheresis, different modalities, but usually done every other day for a total of 5 sessions, or in some cases the use of intravenous immunoglobulin, IVIG. If we move on to the symptom management, and again I want to emphasize that in the comprehensive control of multiple sclerosis, we not only put patients on the medications that I just described to try and reduce the risk, but we need to turn around and recognize that the patients have symptoms right now here that need to be addressed. And again, we're going to describe some of them briefly to see what we can do for those. Regarding motor function and gait, we have weakness, we have spasticity, sometimes secondary contractures, ataxia, and tremors. In the sensory arena, we have decreased sensation or abnormal sensations such as paresthesias or allodynia. In the visual area, we have blurred vision, even blindness, usually secondary to involvement of the optic nerve. We can have diplopia or double vision secondary to involvement of the brain stem. And we can also have oscillopsia. Oscillopsia being the perception of the patient of nystagmus. And nystagmus is not uncommon in multiple sclerosis. And of course, that can be very impactful regarding visual function when you're looking at objects that never cease to move. Bladder and bowel, we have discussed some regarding frequency and urgency, but we also have to recognize that many of our patients actually can have incontinence. The most common type of incontinence that we see is just an urge incontinence. In patients that have spastic bladder, they have the urge to go evacuate their bladder, but they do not have enough time to make it to the restroom because the bladder is actually contracting, and they are going to have an episode of incontinence at that point in time. Sexual manifestations include again both male and female deficits. Erectile dysfunction is quite common in males with multiple sclerosis, but on females we also see dyspareunia or pain with sexual activity and inability to achieve orgasm. Decreased libido is also quite common in MS. Cognitive problems, and I have mentioned this several times, and I like to spend a little bit more time regarding this specific area. The cognitive dysfunction, like many other deficits in MS, is of great variability. Different patients will have different types of manifestations. There are certain things that we see more commonly, and those are the ones that are listed on the top under this category, and they include attention span reduction, inability to concentrate, reduced ability to multitask, and some short-term memory deficits. Those are the things that in the clinic we tend to hear from our patients more commonly. Unfortunately, in some cases, the cognitive dysfunction can progress to a point in which the patient actually has true dementia, and that is something that we need to monitor and understand better to be able to intervene. Pain again can be secondary to neurological processes, due to involvement of nerve fibers that are responsible for sensory transmission, but also through musculoskeletal processes secondary to alteration of gait or due to spasticity. We also have bulbar involvement like dysarthria or dysphagia, and then fatigue, one that again is quite common. We have many different modalities to intervene for all of these symptoms that I have just described. We do not have time today to go through each one of them, and some of them will be the topic of future presentations. I want to spend my last 5 minutes before we go into the question and answer session to highlight some of the aspects that the different healthcare providers that are dealing with multiple sclerosis patients provide to these individuals. Physical therapy is very important in MS. We have been talking about how there are so many types of physical manifestations in our patients that of course require the intervention of PT. One of them, ambulation, mobility. It is quite commonly involved in MS, and this is due to many different types of processes, and that is where the physical therapist needs to evaluate the patient properly and recognize which are the deficits responsible for the manifestations. Is this patient having ambulatory deficits due to weakness? Is it primarily due to spasticity, or is it due to sensory deficits causing ataxia? Balance can be affected by some of these same modalities, same as posture. For patients that have more significant deficits, in addition to concentrating how to ambulate better or safer, we need to concentrate in what is realistic for them, things like transfers, to be able to give them the independence to transfer by themselves in a safe manner. Range of motion is very important for patients that already have some degree of spasticity to prevent contractures and enhance their ability to participate in other modalities of rehabilitation. And we need to recognize as well that many of the motor deficits that our patients have, even though for the most part are neurological in origin due to the damage of the brain or the spinal cord from MS, that some of that weakness that we see in our MS patients sometimes come from basic disuse. Patients are less mobile for other reasons, to include fatigue. They tend to be more sedentary, and we have a disuse atrophy that is superimposed on their neurological deficit. And for a committed patient and a committed physical therapist, that is a deficit that can be recovered relatively easily in this context of MS dysfunction. Occupational therapy is also very important in MS. The patient's ability to provide self-care regarding mobility, dressing, bathing, grooming, eating, of course, all very important functions that the OT works with our patients. That can result secondarily, of course, in increased productivity, both at work and in their home environment, and very important, their ability to enjoy leisure activities, both social and just recreational. Speech-language pathology in MS helps our patients with bulbar manifestations, either dysphagia or dysarthria, and some of them also are able to work on some specific cognitive issues with our MS patients. And then we have the case managers and social workers that are paramount in allowing the patients to access care properly. They help our patients deal with a lot of the insurance coverage issues, financial resources, transfers, mobility, access to medications, modification of home environment so that the patients are able to provide care for themselves, employment issues, as well as intervention in crisis, counseling, and emotional support. That gives you a sense not only of the dimension, the pathophysiology, and the treatment of MS, but also for the need of having a comprehensive and multidisciplinary approach to the treatment of multiple sclerosis. The neurologist alone is not going to be able to treat an MS patient properly. It requires a team of people that are dedicated to the treatment of MS, and in many communities, even if you do not have that setting of a comprehensive MS center where you have the neurologist specialized in MS and the physical therapists and occupational therapists that are right there able to provide that care, in the community we need to replicate that same sort of situation, and physical therapists and occupational therapists and physicians in the community need to be aware of these deficits, need to be aware of how we need to approach the disease so that when they see patients with MS they can provide the same level of care. At this point in time then we're going to open the session for any questions that you all might have, and as I understand, you should be able to type your question and I will be more than happy to address that. I'm going to check right now to see if there are any that have been sent so far. We don't have any at this time, and I'll just give ourselves a little bit of time to see if anybody wants to type and refer questions to us. I want to remind you that there are other, we have a question that just came through. What are my feelings about CCSVI? Just briefly for the audience, CCSVI stands for chronic cerebral vascular insufficiency. I'm sorry. This is a condition that was described a few years ago by an Italian physician who made an observation, and he believed that patients with multiple sclerosis had a higher incidence of narrowing of the blood vessels that drain blood away from the brain and the spinal cord, the jugular veins and the azygos vein. His findings were somewhat controversial because the methodology of his study was brought into question, and the results were perhaps too dramatic, usually not what we see in clinical practice and in medical research when you have 100% results for one disease and very low frequency for other diseases. What he was finding that this narrowing of the blood vessels in MS patients was present pretty much for all of them, while it was very uncommon for patients that did not have MS, had other neurological diseases, or that were healthy controls. Since then, many studies have been done, many of which have been supported by the National MS Society through funding of specific research. We do not have the entire results of those studies. Some have been already published, at least with preliminary results, and what we are seeing, and the consensus in the MS community at this time, is that perhaps CCSVI is not a conditioning factor for multiple sclerosis. The validity of the findings, again, has not been replicated in other studies, and the support for this type of approach really has been dwindling in the recent past. We'll wait for any other questions. Very good. With any other questions, then I want to thank you for participating in the program today, and again I encourage you to thank you very much.